than 24 hours with acute anterior myocardial infarction. So you see, I place a stent. You see a beautiful result. I place a 3.5 to 18 millimeter, excellent result. And you see the 1 year follow-up with this patient. In spite that the artery is open, the left ventricular ejection fraction is 25%. This is a typical patient with ischemic heart failure. Look the follow-up. The 2 year follow-up, the artery is still open. But look, the ejection fraction at 2 year follow-up is the same. So what to do with this patient? Is taking the best medication, beta blockade, all enzyme converter. So this is the typical patient with ischemic heart failure. And we have another group, it's non-ischemic group, non-ischemic heart failure group. This patient do not have problems into the coronary artery, but they ended with heart failure due to high blood pressure, they are obesity, they are a diabetic patient, or maybe they have some viral disease like Coxsackie, echovirus, or most of them receive chemotherapy due to leukemia or lymphoma. Like this patient, you see, normal coronaries, completely clean coronaries, no lesions, and look the ejection fraction. And the ejection fraction is 25% with normal coronary. The past medical history of this patient is a past medical very high blood pressure. So this is the two group of patients before I start my study, just to remind you. And what did all of the randomized and non-randomized studies tell to us? We have a lot of studies. You see a lot of publications in Circulation, in JACC, in New England Journal, European Journal of Heart Failure. But the most important for all of us is that we have 3 systematic review and 3 systematic meta-analysis. And this is very important because these systematic are telling to us what did they find with all of these randomized studies. And I brought to you this meta-analysis that they was performed, this systematic review was performed with 4 groups in the United States. Group from the Harvard University, group from the Texas Honey Newton, the group from the Michigan, and the group from the Mayo Clinic. And what did they tell to us? That the left ventricular ejection fraction is better comparing to the control group that taking the best medication. The infarct scar size are also better, the group that receives stem cells. And look, the left ventricular end systolic volume is better also. So the conclusion of this meta-analysis is that the therapy with the stem cell is safe. This is the best conclusion, the first conclusion in all of the phase 1 trials. Right now we are facing the three trials. So the available evidence suggests that BMC, stem cells transplantation, is associated with modest improvement in physiologic and anatomic parameters in patients with acute myocardial infarction and also chronic ischemic heart disease. Look this word, above and beyond conventional therapy. So this is very important. And recently, 4 months ago, came this study from the German group of Professor Bob Strauer. Professor was the first physician in the world who performed the first stem cell in patients with acute myocardial infarction and heart failure in 2002. He published in Circulation. And this study, that's called STAR Heart Study, was published 4 months ago at the European Heart Journal, and he put 391 patients and put in 2 groups, the group that received BMC, autologous stem cell, and the group that received control group, the best medication. Look, the ejection fraction at 5 year follow-up is better for the group that receives stem cells comparing the group that is the best medication treatment. Look, the 5 year clinical follow-up of the Kaplan-Meier analysis, the patients are dying less, less death, less myocardial infarction, and this word is very beautiful. Less rehospitalization for this kind of patients. No more heart failures, no more congestive heart failure, so this is very important. So we are changing the prognosis of these patients. And look, this the survival, also the same. So we are changing the prognosis of these patients. So the conclusion, the summary of this study from the German study. This study was designed to analyze the ventricular performance and mortality in a large population of patients with chronic cardiac failure due to ischemic cardiomyopathy. Results show that BMC therapy, in addition to the best medical measures, exerts beneficial long-standing effects on ventricular function, quality of life, and survival. Magical words. So I brought to you this study. I've been working with stem cells almost 6 years. I have done more than 400 patients with heart failure. I think we are still learning, of course, we are still learning, but this group of patients is very important because the result that I'm going to show, I put in this group patient with functional class 3 and functional class 4 with an ejection fraction less than 25%. And in two groups, ischemic and non-ischemic. So the primary endpoint of this study that was performed in Lima and a patient also with Argentina is to assess the safety of using our autologous stem cells by this technique, the retrograde technique that I will show you later, in patients with an ejection fraction less or equal to 25%. And the secondary endpoint is to assess the efficacy of these autologous stem cells in terms of symptoms, functional class, and left ventricular ejection fraction by nuclear medicine. So two groups, ischemic and non-ischemic heart failure with left ventricular less than 25. And all of them were no possibility to perform more percutaneous or surgical or cardiac resynchronization therapy. So all of them have cardiac catheterization and nuclear medicine before, after 1 year, 2 years, and 4-year follow-up. So you see the baseline characteristics of the group are the same. The age is not significant. 30% of 25% of these patients were in functional class 4. Functional class 4 is shortness of breath and minimal exertion at rest. And the 75% of the patients were in functional class 3. And the median ejection fraction in the ischemic group was 18% and 24% into the non-ischemic group. So the technique is very simple. There were two hematologies. It takes no more than 10 to 15 minutes, local anesthesia, and we used to aspirate 400 cc. And we were waiting because this is we were working with a manual processing. We have to wait 2 to 4 hours. I will tell you that we began with PRP the patient, but this study was performed 5 years ago. So the preparation of the stem cells was manual. So we use the starch, not the fiber. We use the starch to separate the red cells. All of the patients had a small fraction for cell counting. This is my cath lab, my son de santé. This is the bone marrow aspiration. This is the back, where we used to send for, and this is the stem cells ready, 50 cc ready to put in the, and I am interventional cardiology, and looking the right position to inject the cells. The technique, what is described for the first time in the world by the Argentinian group, Dr. Fernandez Viña, who is here today. This technique was published on the TCT in 2003 and 2004 for the first time. So this is the technique. It's the most simple technique, done with local anesthesia. I can do it by the jugular or subclavian vein, by the neck. I can do it by the groin. Right now I'm using only 5 frames in producer sheet. And you see here, when I am in the right position, I place a balloon and inject it into the coronary veins. It's not the artery that you are seeing. So you see, I can do it by the groin, you see, and this is the left amplatz, and then putting the balloon in the right position and injecting this is the content of that. In the right position, we put stem cells. This technique was described by Dr. Viña. So at that time, all of the patients had to stay at the hospital in the coronary care unit because we didn't have enough experience. Telemetry and serial enzyme control. In the follow-up, all of them perform SPECT medicine, all of them. Baseline, 1 year, 2 year, and 4 year follow-up. So look, the end-diastolic volume, this is the ischemic group and this is the non-ischemic group. 1 year and 4 year. It's a tendency of improvement of the end-diastolic volume in both groups, but the P was not significant, the end-diastolic volume. But you see the end-systolic volume. It's a significant improvement in both groups with a significant P. and look the left ventricular ejection fraction, miracle. In the ischemic group, we improved the median 10%.